Professor Kamran and Dr. Pratima, do we wait for 5 more minutes and see if more people join us, or should we start? Because I'm also mindful of your time.
I'm good to wait for a couple of minutes.
Okay. Yes, Dr. Vikrant.
Oh, no, I am just stretching.
Great.
So I'm just tired. Thanks.
Cool.
Hi, Amit.
Yeah. Hello, sir.
I'm here without the video. So I'll be listening and watching you.
Okay, sir.
This is Dr. Prashant, Andhra Pradesh.
Yes, sir. Yes, sir. Sure. Yeah. Perfect.
Right. We are waiting.
Hello.
Sir, when shall we start? Amit?
Yeah.
Sir, when are we starting the webinar?
Yes. In just a couple of minutes, maybe 2 minutes more. It's at 4:30.
Fine, sir. I am ready. I am ready, sir. Thank you.
Okay.
Right.
Yeah, and I think because it's a vacation time and Christmas breaks, so I think we would not have that much of a global audience with this webinar. But we hope that this would be shared across once this is recorded, and would be useful for participants globally, and they would be able to access this from our UN Tobacco website and through our Twitter and other social media platforms. So it's just in a minute, maybe I would start introducing the speakers, and hope as we go on, more people would join in for this webinar. This webinar series is on the smokeless tobacco control as a series of webinars supported by the Government of Norway grant through the WHO Convention Secretariat. We have already done 5 webinars in this series. This is the penultimate webinar that we are doing, and we have the last one that is going to happen in maybe a couple of weeks' time on pictorial health warning, packaging and labeling of tobacco products. As a background to this webinar series came up after our last year's policy meeting. It was inter-country meeting on smokeless tobacco. Global audience was part of this, and they recommended policy areas that needs to be worked on, including in terms of research and policy priorities on a smokeless tobacco. So this webinar series actually dealt with the 7 key priority areas in these 7 webinars. And this is one of the key policy challenges, and also in terms of real challenges while we talk about smokeless tobacco, cessation or SLT cessation. So, and no better experts than we have today with us, Dr. Pratima Murthy from the NIMHANS and Professor Kamran Siddiqi, Professor in Public Health, Department of Health Sciences from University of York. And I'll give introduce today's first speaker, that is Dr. Pratima Murthy. Professor Murthy is Professor of Psychiatry and heads the Center of Addiction Medicine at the National Institute of Mental Health and Neurosciences, NIMHANS, in Bangalore, India. She is a fellow of the Royal College of Physicians and Surgeons, Glasgow. She is co-director of the Fogarty ICHORTA training program in behavioral disorders. Dr. Murthy has been a consultant to several international agencies like the United Nations Office on Drugs and Crime, the International Labour Organization, and the World Health Organization in area of substance abuse, substance use disorder treatment, prevention, and policy. Professor Murthy was an international trainer for tobacco cessation training for Bhutan and Timor-Leste, and for a TOT for the WHO CRO countries. She was the lead author of manuals for tobacco cessation for doctors and dentists and nurses and community health workers for the WHO CRO. She was involved in developing the national guidelines for tobacco cessation in India. She is one of the international consultants of the WHO ITU mobile cessation program for tobacco as well. She leads the tobacco quit line for southern India. She has been involved in developing manuals to reduce risk factors for non-communicable diseases for the WHO office in India. So I welcome Professor Murthy to this webinar, and the format is that there's a 20 minutes talk, and then the 20-minute talks by the other speaker, and we get 20 minutes for discussion at the end. So over to you, Professor Murthy.
Hi, greetings from NIMHANS. Thank you very much for inviting me to talk on this particular topic, which I think is very, very important and relevant, not just in the Southern Asian region, but globally as well. So what I propose to talk to you today are the challenges in the cessation of smokeless tobacco. In terms of the format of the presentation, I'll first enumerate and discuss the challenges that we would face with smokeless tobacco use, the experiences with smokeless tobacco cessation, particularly from India, the changes in the prevalence of smokeless tobacco cessation, in the use of smokeless tobacco between the Global Adult Tobacco Survey 1 and the round 2, and we'll see that this is part of the efforts of the Empower and the FCTC that have occurred in India, and of course conclude by talking about the steps to improve smokeless tobacco cessation, both in India, the region, and perhaps globally. So the first challenge is that a large population uses smokeless tobacco. There's data from the Southeast Asia region that it has a double burden of both smoking as well as smokeless tobacco use. We know that smokeless tobacco use is higher in rural areas and amongst the poorer communities, both in the Southeast Asia region as well as the African region. And therefore, it's very important to look at smokeless tobacco use in the context of larger socioeconomic situations in any particular country. And two important populations are particularly affected by smokeless tobacco use, and that's women globally, where smokeless tobacco is a predominant type of tobacco that they use. And the other worrying thing is that smokeless tobacco use among adolescents in the Southeast Asia region is higher than smoking. So many of these factors lead us to actually, turn our gaze from merely smoking forms of tobacco use to the very large majority that does use smokeless tobacco in our region. The second challenge is that there are a variety of smokeless tobacco products in the South Asia region, particularly in India. Those of us who work in India are familiar, with gutka, which used to be a very prominent form of smokeless tobacco use, kheni, mawa, mishri, tambaku, kaddi pudi in southern India, snuff, dentifrices, which people use, like laldan panjan and so on. And this kind of variety of products, which are often not very well regulated, really is a big challenge in terms of control of smokeless tobacco use in the region. The other very important factor to note is that smokeless tobacco has, the different products have different levels of nicotine content in the package material. Some of it is very loosely packed. Even the ones which are packed prior to sale have a varying amount of nicotine in them. A typical example is, we did a analysis of nicotine content in different forms of tobacco, and you'll see that the average nicotine content in terms of milligram per gram varies hugely across different tobacco products obtained throughout the country. We know that with smoking products as well, like PDs, for example, there's a lot of variability in nicotine, tar, and other content, but smokeless tobacco uses an even greater challenge because of this wide variation in the production, in the packaging, as well as in the sale of these products. The third challenge, and I think this is really the most important challenge, are the positive expectancies with smokeless tobacco use. We did a study where we asked people their main reasons for the use of smokeless tobacco, and a very cheap form of enjoyment, something that they could pass their time with, relieve themselves of their boredom, relief from tiredness, relief of mood, and the fact that it formed a habit. And for a lot of people, ease of bowel movement in the mornings were important reasons why they use tobacco. There are people who shift from smoking forms of tobacco to smokeless forms of tobacco when smoking is prohibited. And we know with laws which prevent smoking in public places, people who have a lot of urge to use tobacco may switch over to smokeless forms of tobacco. One other reason is that, again, at the workplace, people are not allowed to smoke, and it's easier to chew as well as work. Chewing forms of tobacco are also much cheaper than smoking forms of tobacco. And we all know that a lot of point of sale advertising, where very colorful packaging of pan masalas containing both with tobacco and without tobacco are very often, very attractive to, for people to use. Here are some verbatim responses of smokeless tobacco users, which really indicates how much of a expectancy is associated with smokeless tobacco use. So a poor woman who said, who felt that only a few people get cancer. I know I spend a little money on it, but why should I spend my entire money on the household? I don't have any other luxuries. I don't indulge myself in any other luxuries. It's just a few clothes. I don't even spend on clothes and bangles. It's just a few rupees on smokeless tobacco. Others feel that there is no health problem associated with smokeless tobacco, despite all the ads that go around. Their perception is that it helps digestion and bowel movement. And when the person stopped, the person felt that the world was coming to an end, which is the kind of agitation and restlessness the person feels when they are trying to quit the use of tobacco. Another person said that the person doesn't chew at the workplace because of fear of losing the job, but the person would rather quit the job than actually quit tobacco. And this respondent felt that, for the poor, there was really no other, substitute. The rich had better, kinds of tobacco that they used. For the poor, there were very few alternatives. And the smokeless tobacco the person was using was was the only alternative the person had. The other thing is that with smokeless tobacco, there is a perception that no harm has occurred despite several years of use of smokeless tobacco. And some people feel that it's unnecessary to deprive the public of this very cheap luxury. Instead, they should be focusing on alcohol because very little is spent on tobacco and it doesn't cause problems to other people. Another person felt that when doctors themselves chew tobacco, why on earth should the public stop using tobacco? Doctors also very often ask about smoking forms of tobacco. And this person did not report chewing forms because the person wasn't asked. And this tells us something about the health consultation and how, how frequently in the consultation, one might omit asking about smokeless tobacco use. The next challenge is really the normalization of smokeless tobacco in communities. We all know that in many countries in Southern Asia, particularly in India, the use of pan with areca nut is extremely common. It's culturally sanctioned in many parts of the country. And very often, tobacco is combined with the pan masala. We know that very young girls, as young as 6 or 8, learn to use smokeless tobacco because they have grandmothers, aunties, other relatives using this. So both for young girls and young boys, there's a lot of modeling of the use of smokeless tobacco that occurs within families. Peer approval. I've got my house getting painted just now, and all the laborers who have to deal with paints, long hours, working in the sun, they all tend to use chewing tobacco together. So there is a lot of peer approval for the use of smokeless tobacco. It's very easily available. Every corner shop in many of the countries sells smokeless tobacco at very cheap prices, so it's very easily obtainable. The perceived psychological benefits in terms of relaxation, in terms of reduction of aches and pains, reduction of toothache, elimination of hunger so that housemates can work longer because they're chewing tobacco are very, very important realities in terms of the continuation of smokeless tobacco use. And of course, in many of the countries, particularly in the South Asian region, the social as well as religious sanction kind of perpetuates the use of these substances. When you look at the factors that influence the initiation of smokeless tobacco use and the maintenance of smokeless tobacco use, some of the initiating factors, apart from modeling, which I mentioned, are also to feel warm, to reduce discomfort after a meal. For men, of course, it does occur more in a peer group setting, out of curiosity, and as an alternative to smoking. For women, the reasons for continuation that were mentioned in focus groups and interviews that we did were that it had become a habit, and there was a significant amount of tension when they were not using this. And they could not kick the habit because, it led to a lot of discomfort when they were stopping tobacco use. In terms of the societal responses, the use is accepted, in the community. There is some resistance for women from employers, especially housemaids who go with a wad of tobacco in their mouth. But for men, it's widely accepted. And of course, the advantages that I mentioned, are there for both men and women in terms of being able to use and work at the same time. The fifth challenge, and I think this is a challenge that is perhaps unique in the developing world, are that there are several women who use tobacco. And adverse maternal and fetal effects from maternal smokeless tobacco use have now been well demonstrated. And there are risks for smokeless tobacco use in the mother, higher levels of maternal anemia, mothers being underweight, pregnancy-induced hypertension, antepartum hemorrhage, oligohydramnios, polyhydramnios, and postpartum hemorrhage in women who are pregnant and using smokeless tobacco. And of course, in terms of adverse fetal outcomes, there's growing literature of the effects of maternal smokeless tobacco use during pregnancy in higher odds of stillbirths, fetal distress, low birth weight, preterm birth, and small for gestational age. So it's very, very important to actually make sure that services are available for women who get pregnant in terms of smokeless tobacco cessation. The other very important vulnerable group are adolescents. And we know that smokeless tobacco is used by adolescents in more than 100 countries. Of course, the prevalence is even more prominent among boys in low-income and low and middle-income countries, but girls are not very far behind. Again, these products are very easily available and accessible. Taxation on smokeless products is lower than for smoked products, and therefore affordability is much higher. That oral cancer is increasing in a younger age group in some low-income and low-middle-income countries. And to me, this is the biggest harbinger of troubles to come. We know that for adolescents, many of drugs are gateway drugs, and therefore perhaps smokeless tobacco as well as other forms of tobacco are important gateway drugs that we need to control if we are to prevent the graduation to other drugs. And therefore, there is a huge window of opportunity to try and prevent smokeless tobacco use among adolescents. In terms of the experiences with smokeless tobacco cessation, India possibly has a very rich experience, particularly in the 1980s and 1990s, when cancer prevention programs, were taken up in a big way. And there's some very good research from places like the Kidwai Memorial Hospital in Karnataka, in Kerala, and so on, that with proper health awareness, with proper clinical examinations in the community, the health awareness leads to much better cessation rates compared to people who are not exposed to health awareness. So there's some very good literature from India to suggest that these kind of awareness camps have led to a reduction in the use of smokeless tobacco. Similarly, when we actually initiated the tobacco cessation clinics in India, in the early 2000s, and we looked in some of the tobacco cessation clinics of 1 year self-reported quit or significant reduction of tobacco use. We did this across different sites in the country which were running tobacco cessation clinics, and you'll see that in practically all the sites, when you looked at a 1 year follow-up and self-reported abstinence rates, people who were smokeless tobacco users reported much higher tobacco cessation, except in the case of Mizoram. And in the discussion, we can actually try and see, why the trend was similar across all the other sites and different in the northeastern state of Mizoram in India. What I'd like to emphasize here is that the efforts, with little effort, people can be helped to get rid of smokeless tobacco use, possibly slightly easier than for smoking tobacco. And that's possibly because smokeless tobacco doesn't produce the sudden increases or reductions in nicotine content as does smoking tobacco. And perhaps, it's a kind of smoother, detoxification or de-addiction process as far as smokeless tobacco is concerned. In India, we've had some recent experiences with the mobile cessation, which was initiated by the government of India a couple of years ago, where people can register giving a missed call to a toll-free number. They receive text messages about the needs and the ways of quitting. There's information available on the National Health Portal on various things of why should a person quit, how to deal with craving, how to improve sleep, and simple strategies to actually quit. And through the National Health Portal, they've till in the recent 1 year of the portal, they had more than nearly 2 million calls. And the content of the M cessation consisted of 150 behavioral change SMS messages, including health information, tips on quitting, and encouragement for those who wanted to quit. Recently, a program evaluation was carried out. 10,340 people who had registered for the M cessation were evaluated, and amongst them, there were 3,362 ever users who provided complete information on their tobacco use patterns and their quit rates. A sizable number of them, 43% of them either were users exclusively of smokeless tobacco or combined both smokeless and smoking forms. And following the registration onto the M cessation, more than 2/3 made a quit attempt after the registration, and overall past 30-day quit rate at 4 to 6 months of follow-up when they were contacted was nearly 20%. Many of the respondents found the M cessation program very helpful. And therefore, this is a great shot in the arm that public health interventions, which can reach a large number of people through simple behavioral tips, can help people, quit tobacco. However, apart from text messaging, only about 15% of respondents reported access to any other forms or tools or aids for tobacco cessation. And of those who had received some or other additional aid, about 1/3 reported having access to counseling or nicotine replacement therapy, and only 1/5 reported access to medications, including bupropion, access to a quit line, or specific support for smokeless tobacco cessation. And I think that really tells us that there's a lot to be done in terms of developing and reaching interventions for smokeless tobacco to a larger number of people, particularly in underserved and rural areas. We've had some preliminary experiences with the tobacco quitlines. It was started in India at the VP Chest Institute in New Delhi in 2016. In this year, it's been expanded. We run a tobacco quitline for Southern India at NIMHANS. The Tata Memorial has initiated tobacco quitline, as has the Regional Cancer Center in Assam. The VP Chest Institute reports early, encouraging preliminary results, with 38.8% of registered callers reportedly, having quit on the quit date. Of course, these are preliminary experiences. We'll have to wait for published data on this. But again, in a country where people have very great amounts of difficulty in accessing clinical services like the quitline may be a very, very useful and easily accessible intervention for people to quit. In terms of the effects of policy, I think one of the important things that happened in India was the ban on gutka. And with the ban on gutka, which is a form of smokeless tobacco use, a very common form, in fact, a lot of young people of all ages actually were using gutka, and there's been an overall reduction in gutka use. There was a study conducted in 2014 looking at both retail environments as well as talking to both ex and present users of gutka in 7 states in the country. And the respondents reported a lower consumption of gutka after the ban. But of course, what's happened with the ban is that tobacco companies now sell tobacco in separate pouches and the pan masala in separate pouches. And therefore, people now combine it and use it. So the hardened tobacco users, which is about 15% of the respondents in this particular study, continue to use gutka. In fact, the fact is that gutka has not been entirely eliminated, but in addition to gutka, people also mix pan masala and tobacco and continue to use it. However, I think the important thing is that a substantial number of people have reduced their tobacco use after, at least the gutka use, after the ban. It also happens that people, it's very important to remember that people can shift from one form of tobacco to another, from one drug to another. And therefore, I think when we are planning prevention strategies, one must not look at a single drug alone, but really look at all substances of use, substance use disorders, and try and see if a coherent response can be used for all of them. As I mentioned, there has been an overall positive impact with the tobacco control measures. And an illustrative example from India is the Global Adult Tobacco Survey 1 and Round 2, which shows a reduction overall in the current smokeless tobacco users from about 25.9% to 21.4%. Among males, the reduction is is from 32.9 to 29.6%, and from women from 18.4 to 12.8%. The reduction in smokeless tobacco use is not as much as for smoking tobacco, and that again possibly is explained by the fact that people can chew in public while they cannot smoke in public, and of course the fact that it's approved in many social contexts. So what can we do in terms of scaling up tobacco cessation services? Health providers need to definitely focus on asking about smokeless tobacco use in addition to smoking in any kind of healthcare encounters. Integrating tobacco cessation with alcohol cessation in primary healthcare does lead to increased sensitization of the public, does lead to increased quit attempts. So it's something to look at in terms of combining strategies to look at all substances of abuse, like I mentioned. The packaging and display of ingredients is a big problem because of the nature of packaging and the way sometimes loose tobacco is brought. The biggest thing is community engagement and in some ways a denormalization of tobacco use. For health providers, oral examination as a necessary part of the physical examination to identify smokeless tobacco use and therefore offer timely intervention in a healthcare consultation context. Linkages with NCD programs, which need to also address smokeless forms of tobacco along with smoking forms of tobacco. And finally, I think we need to look at an ecological model of tobacco use. As I mentioned earlier, poverty, illiteracy, lack of access to recreation, lack of ways of reducing anxiety are all important nidus for the use of drugs like tobacco. And therefore, we need to look at an ecological model and see what environmental factors support the use of tobacco and what environmental factors might reduce the use of smokeless tobacco and address those ecological factors. We really have miles to go as far as smokeless tobacco cessation is concerned in our country. We need to denormalize smokeless tobacco use in every context, socio-culturally, in religious contexts, and so on. People need to have a wider menu of resources to quit. We need to expand cessation to group and community settings. We need all our health professionals with some degree of training in brief counseling so that they can be effective community agents of change. We definitely need increased accessibility to cessation treatments. What's actually lacking is research in smokeless tobacco cessation. I'm sure Professor Kamran will talk about some of the existing research, but we certainly need much more research in what helps smokeless tobacco users to quit. Apart from, we know that behavioral interventions work, but in addition to behavioral interventions, what are the pharmacological interventions that are cost-effective in smokeless tobacco cessation? We also need to extend the reach to completely unserviced areas, like, for example, prison populations, correctional settings, etc., where smoking is frowned upon, but smokeless tobacco use is quite rampant. And finally, we need to monitor the trends of smokeless tobacco. We know that these trends can change over time. We also know that there can be shifts from smoking to smokeless and from smokeless to other forms of use of tobacco as well. And therefore, we need a proper monitoring strategy to see whether these minor reductions have sustained. I'd like to end by saying that smokeless tobacco is really a huge health problem that we in India, as well as other countries in the South Asian region, face. Some of the lessons common to smoking can be applied to smokeless tobacco, but merely from the fact of the socio-cultural aspects of smokeless tobacco use, we also need to design our interventions specifically to address the denormalization of smokeless tobacco use. Thank you very much.
Thank you, Professor Murthy, for your enlightening information on cessation and in terms of how the smokeless tobacco is being considered as a policy, and also in terms of field of cessation. Some of the points that, in terms of, if I could bring back, is one of the things that intrigued me also is when we talk about smoking, we can always think of secondhand smoke and as a human rights challenge, and it affects others, but that is something which is missing in the smokeless tobacco control discourse, and that's become a challenge when we, in terms of want to make stronger policy options. I think that is a very well made point that you have brought out. And cheap SLT is I think another concern. So taxation is an issue which we need to look at when we are dealing with smokeless tobacco, because when it is already known and documented that if you raise cigarette taxes, its use decreases. The same should be true for smokeless tobacco products, and I think that is not happening because the taxation in smokeless tobacco products is little different. You have also made the point that it acts as a gateway drug, so which is another issue for us. And health awareness, cessation, and one of the things that we are in India as in terms of looking at tobacco control policy, we have seen that flavored tobacco has become a big challenge, and it is important that the regulators look at the flavored tobacco from the food safety and standards laws, so that their use and things can be curbed. So I think these are some of the interesting points, and as we get into the discussions at the end, we would some of these would come back and we can interact on this. So now I would like to come back to Professor Kamran Siddiqi, and I would like to introduce him. Professor Kamran Siddiqi is a professor in public health from the Department of Health Sciences, University of York in the United Kingdom. Professor Kamran Siddiqi is a clinical academic with a background in chest medicine, public health, and epidemiology. He works at the University of York as a professor in global public health. He also holds an honorary consultant post in public health medicine at Public Health England. He is the director of two major research consortia, the EU-funded Horizon 2020 Consortium on TB and Tobacco, and the NIHR-funded Global Health Group on Smokeless Tobacco, which NICPR is privileged to be a part of, ASTRA, called the ASTRA. He also co-leads the respiratory disease group at the Global Alliance for Chronic Diseases. He is the deputy editor of Nicotine and Tobacco Research Journal. Previously, Professor Kamran has worked as a consultant in chest medicine and in public health education advisor to National Institute of Health and Care Excellence, NICE, and medical officer at the World Health Organization. He chaired the tobacco control section at the International Union Against TB and Lung Diseases between 2015 and 2017. He has served at several national funding boards and NICE guideline development committees. Professor Kamran has published extensively on TB diagnosis, tobacco control, and tobacco cessation. We look forward to hear from him, and I give now the floor to Professor Kamran.
Thank you very much for introducing me and giving me the opportunity. I hope you can hear me all right, but do let me know if you're struggling. So I'll start by basically congratulating NICPR for such an excellent endeavor. When I was asked to present this webinar, I felt really proud that I'm contributing to this very, very important area and obviously very important endeavor from NICPR. I think after listening to Dr. Murthy's excellent presentation, and by the way, Dr. Murthy and I have known each other for a long time, so I've learned a lot of things from her. And today as well, I've learned a lot, and probably I don't have a lot to add here. One of the important things I learned today was the excellent experience that we have of smokeless tobacco cessation in India, which I think probably needs a bit more highlighting in the evidence base that we have, because currently, as I will show you, the evidence base for smokeless tobacco cessation is quite scanty. But of course, we have a lot of experience, particularly in India, and there's a lot to learn here, which need to be, I guess, framed in more sort of evidence base. So what I plan to do is give you just a very brief overview of what evidence do we have on smokeless tobacco cessation and what evidence do we need going into future, which I think leads very nicely from the previous talk. So if I can have the next slide, please. Thank you. So I don't need to give you a long lecture on smokeless tobacco, as you already know, and Dr. Murthy has already explained. But it is obviously, I would say, not just a problem in India. Although India has probably the highest number of smokeless tobacco users in the world, but it is essentially a global problem. I think up to 140 countries, people consume smokeless tobacco. South Asia in general and Southeast Asia have got probably the highest number of smokeless tobacco users in the world. About 250,000 people use smokeless tobacco. And what it says is that 25% of the world tobacco is consumed in the form of smokeless tobacco. Now, the interesting aspect of smokeless tobacco is that, of course, not all forms of smokeless tobacco are as lethal as others. But the one that we are interested in, the types that we are interested in, we're talking about today, are definitely the most lethal and unregulated products, and they are used in South Asia. And you would also be surprised to know that a lot of these products are used in London and in various cities in the UK where I live. And we have a very sort of important public health concern about smokeless tobacco use, which is primarily restricted to South Asian populations living in the UK, but it is nevertheless an important public health issue. Next slide, please. Okay, so one question we should ask, that why do smokeless tobacco users need help with quitting? There is some scholarship which suggests that people can quit on their own if they want to, if they're motivated to stop. They can probably quit on their own, but do they actually need help with quitting? So let's challenge this assumption. Next slide, please. So this is some study, a research that my colleagues and I conducted in Bangladesh, where we had a group of 200 smokeless tobacco users in Bangladesh, adult tobacco users, and they were not using any other forms of smokeless tobacco other than smokeless tobacco. They weren't smoking or anything else. And the average time that they were using smokeless tobacco was about 11 to 12 dips per day. What we found when we measured their cotinine levels, that their cotinine levels were about 361 nanograms per milliliter. And as you can see, that I've made a direct comparison with another prominent study which was conducted in cigarettes, among cigarette users in Europe. And you can see that the cotinine levels, which is, as you know, is a derivative of nicotine and is a direct indication of how much nicotine these guys are having in their system. It's a lot higher, 3 times higher than the same sort of cigarette users. So these are adult cigarette users, and again, you can see that they are using it 11 times per day. So the cotinine levels are 3 times higher in smokeless tobacco users. And if you look at the phagostom tobacco dependency scale and you compare that, you can also see that the dependency is 3 times higher in smokeless tobacco users than in cigarette users. So what is that saying? To me, that's saying one thing very obviously, that smokeless tobacco users are much more addicted to nicotine than cigarette smokers. And we know how hard it is to give up cigarettes. So I suspect that giving up smokeless tobacco use would be even more difficult. And when things are difficult, then people need help. So that's what I suggest, that people need help. Now, this is an important graph, and if you can just make another click, it will show that this is somebody who smokes. There is a struggle between urge to use tobacco and the resolution or the resolve the human being to actually stop. So when the urge is stronger than resolve and tobacco is available, then a lapse occurs. So there's a constant struggle. Somebody who's trying to quit, there's a struggle that they're trying to stop or not smoke. And then there is the strength of the urge to smoke. So when the urge is stronger than resolve, then the person goes back and start using tobacco. And whether it's smokeless tobacco or cigarettes, that applies. So that's the basic concept of addiction. Next slide, please. So you can see, sorry, previous slide. Yes, so you can see from this slide that what we try to do by giving them support, whether it's in the form of pharmacotherapy or whether it's behavioral support, is to try to create a distance between resolve and strength of urge to smoke. So we try and strengthen the resolve and try to reduce the strength of urge to smoke. And the greater the distance is between the two, the more likely that the person will sustain their quit attempts. What we don't want, obviously, is the strength of urge to overtake resolve. And this is the role of treatment in keeping these two lines as far as possible, as apart as possible. So motivation is there. The person does want to quit tobacco, but the treatment or the support can help them to reduce their strength to urge and strengthen their resolve to stay quit. Next slide, please. Okay, so where are we in terms of evidence? If each person here represents a million people, then we have about everybody who uses tobacco in the world. So if you imagine that each person who's holding a card representing a million tobacco users in the world. So there are 12 people. So sorry, 100 million people. So there are about 1.2 billion tobacco users in the world. And next, if you click the next one. Yes, and out of that, a quarter, 300 million people are using smokeless tobacco. So this is just to give you an idea that the problem we're talking about represents almost a quarter of the global tobacco use. Next slide, please. If you look at the cessation studies, by cessation studies, I mean the randomized control trials that have happened to see whether there is an effect of cessation interventions on quit attempts. And I've just compared what has been reported in the Cochrane. As you know, the Cochrane reviews combine all the different cessation studies together. So if you compare smoking cessation with smokeless tobacco cessation studies, then you can very clearly see that there is a huge discrepancy. There are about 450 different studies so far been reported in smoking. Well, in smokeless tobacco, I think there are about 32, 33 studies that have been reported in Cochrane reviews. So there's a big gap, which is disproportionate to the previous slide that I showed, where a quarter of world is using smokeless tobacco. So you can see that very little research has been done on smokeless tobacco cessation as compared to smoking cessation. Next slide, please. And if you look at the global smokeless tobacco use, if let's say everybody here represents smokeless tobacco using consumers in the world, if you do the next click please, then you can see that vast majority of this, actually 85%, is in low and middle income countries. It's in Southeast Asia, some parts of Africa as well. Next slide, please. So where are these cessation studies? Even the small number of cessation studies that I was talking about, 34, 35 studies, none of them have happened in Southeast Asian countries. We are talking about trials. We have a lot of experience. A lot of work has been done on smokeless tobacco cessation. But when it comes to randomized control trials that are big enough to be reported in Cochrane reviews, unfortunately, we do not find those cessation studies. So why do we need smokeless tobacco cessation studies specifically for South Asia? First of all, smokeless tobacco product profiles is very different. The products are very different that we use, the ones that are used in the US or in the Europe. The ones that we use in Southeast Asia are very different. Their user characteristics are different. Behaviors are different from the US. Smokeless tobacco products can be highly alkaline, and as you know, the more alkaline smokeless tobacco products, they enhance nicotine absorption and addictiveness. There's, of course, a strong sociocultural dimension to smokeless tobacco use in South Asia. So therefore, the interventions that work for smokeless tobacco cessation in the US may not work for Southeast Asia. Next slide, please. Okay, so I'm just going to point out to the very small body of evidence on smokeless tobacco cessation that we have so far. This is a study that was done in the UK, but it's done in the UK resident of Bangladeshi women. So I do count that as a South Asian study because it was done in South Asian population. And again, this study showed that nicotine replacement therapy could be quite useful in helping people to quit smokeless tobacco. Next click, please. So again, the same group, my colleagues here in the UK, they did another study in Bangladeshi cohort in the UK, and that also showed very similar results. Next click, please. Yes, and that's just another study that was conducted here. Yes, next. Yeah, so I think there are definitely some studies been conducted that have been reported in international journals. So particularly like to mention this trial, which was conducted in India, which was a double-blind, placebo-controlled, randomized controlled trial, which studied vernaculine for smokeless tobacco dependence. And I think, unfortunately, it didn't show that vernaculine seems to have much effect on smokeless tobacco cessation. But then there was question about compliance, whether people actually took vernaculine, and I think the compliance wasn't as good as you would expect in other parts of the world, in other studies. Next, please. And then very recently, another group from PHFI have conducted a brief community outreach tobacco cessation interventions in India, which not just included cigarette smokers, but also smokeless tobacco users. And again, they have shown that a brief community outreach intervention, which I think included a 10-minute video on teaching yogic exercises, as well as giving them brief advice and access to NRT, did have an effect. But again, the effect was very small. I think it was 2 to 3%. So we clearly need stronger intervention. So these two particular studies, I think, have been conducted in India, which adds to the evidence base. But as I've shown you in smoking research, we have 450 trials on smoking, and here in smokeless, we are only counting these studies as 2 or 3 studies here and there. Next, please. I have worked at the National Institute of Health and Care Excellence, which is called as NICE in the UK, and we have produced smokeless tobacco guidelines for South Asian communities for the UK. And by virtue of being part of that committee, we looked at the evidence, and again, we found very little evidence. And therefore, we could not recommend nicotine replacement therapy, not because we don't believe that nicotine replacement therapy is not going to be helpful, but we don't have trial evidence. And that's why I'm saying that despite all the experience that we have, particularly in India, of smokeless tobacco cessation, unless we do trials, randomized controlled trials of smokeless tobacco cessation interventions, these things are not going to get into international guidelines because the international guidelines, a lot of times, they depend on the highest quality of evidence that's being produced. Next. So as I said, they recommend it. So we've been trying to do some work in developing. We haven't done a randomized control trial yet, but we are trying to develop a behavioral support intervention for smokeless tobacco cessation in South Asia. And I will just very briefly share my experience of doing that. Next slide, please. So it was done in collaboration with our colleagues in Pakistan, in Aga Khan University, and again, Pakistan, like India, also have smokeless tobacco issue at the same scale, and we have been working with colleagues in developing this behavioral support intervention. Next, please. So it was to develop a bespoke behavior change intervention to help South Asians in quitting smokeless tobacco that are living in Pakistan and the UK. And the fact that we want to make it bespoke means that we understand that this behavior of smokeless tobacco use in South Asians is different from the rest of the world. So we cannot just take another intervention that works in smoking cessation and apply it for smokeless tobacco in South Asia, South Asians. Next, please. So for that, we did some preliminary theoretical work. We identified and selected what are the key determinants for smokeless tobacco use and what are the behavior change techniques that are going to help. And that actually helped us to define and refine our resources in a way that made it more relevant to smokeless tobacco cessation. Next, please. So just to give you an example of how we developed this work, so you can see on one side of this table, one of the key determinant of smokeless tobacco that Dr. Murthy has also shown, lack of information on the composition of smokeless tobacco products, unawareness that these products even contain tobacco, and then lack of awareness on the health effects of smokeless tobacco products. So the way we did it was we linked certain behavior change techniques, and then we developed these materials and iPad application to explain what the products actually contain and which products contain tobacco, and then providing information on the harmful ingredients within smokeless tobacco products and what it can cause through an interactive digital platform. Next, please. And we just pre-tested this in a few patients, smokeless tobacco users, just to see whether this is an appropriate way of approaching smokeless tobacco cessation. Next slide, please. We also tested whether our advisors are actually offering these information to our colleagues. So we looked at the implementation or fidelity to the intervention. Next. So the structure of the resource was we used a client booklet and a flip book, and also, as I said, a digital platform. And it contained not just discussing on the harms of smokeless tobacco and benefits of quitting, but also helping to boost clients' motivation and their self-confidence and efficacy in staying quit. And we also provided a lot of information and help and support in managing triggers to use smokeless tobacco, and also managing withdrawal symptoms. Next. Again, there were a number of slides, so I'm not going to go through, but just to give you an example that the kind of resources that we used. Next. Next, please. Next. And in our baseline data, we found that smokeless tobacco was used very commonly, and one of the most common forms were used was betel quid and gutka. Interestingly, we also find very high cotinine levels in our participants, particularly those from Pakistan. Next, please. You can see the saliva cotinine levels were very high at the baseline, but when we actually checked at the follow-up, there was a significant reduction in the saliva cotinine levels. Next, please. And next. And we also looked at different techniques that were offered. And from the green bars, you can see that a lot of these were delivered. We checked whether they were delivered or not, but they were delivered in most of the cases. So I think it was possible to deliver a bespoke behavioral intervention to our patients. Next. Next, please. So there are some details here which you can access these digital platform that we have developed. There are different applications that can be used. Next slide, please. And just before I leave you, I just want to share with you this new group that we have created with the help of at least 2 institutes in India and also with WHO in India. Of course, the National Institute of Cancer Prevention Research is part of that, and MEMC is part of that, Maulana Abul Kalam Azad Institute. So we are trying to address smokeless tobacco use and building research capacity in South Asia. We have involvement from countries in Pakistan, Bangladesh, and now Sri Lanka. And we're hoping that other countries in South Asia, Myanmar, Nepal, and Bhutan would also join our group. Next, please. And our focus is on 4 aspects. We want to establish a cohort of young people and try to assess the impact of policies on youth preventing smokeless tobacco uptake. We also want to study the supply chain of smokeless tobacco, the economic cost of smokeless tobacco use, and of course, smokeless tobacco cessation. And we plan to do a large randomized control trial, multi-country trial, which will involve all 3 countries, Pakistan, India, and Bangladesh, to stop smokeless tobacco use in South Asia. Thank you very much. Thank you for your patience. I'll be very happy to respond to any questions if you may have.
Thank you, Professor Kamran, for your enlightening presentation and giving us an overview of the kind of interventions that the York University and you have been leading on smokeless tobacco cessation. And I would request all other participants and for the webinar, if they have any questions, you can either raise your hand or you can type into the text box and we can have those questions answered by the experts here. I would like to just ask in terms of one questions to both the experts, and because since Professor Kamran was talking about behavioral interventions and even in terms of how even pharmacotherapy and other have been used, but is there any research available where the cessation bit for smokeless tobacco has been dealt with in terms of the kind of nicotine content that these products have, and is that linked to the amount of nicotine or other contents and emissions that they have, and based on that would the cessation interventions be different, and is there any available literature on that?
Not that I know of. I think there are, obviously, as you know, in smoking research, there are 2 ways there are 2 potential ways. One is that you have the opportunity to reduce the amount of nicotine, and that will reduce the amount of addictive properties, and therefore if people are using it, they're not using it because they're addicted. So there's clearly an approach that is particularly popular in the US, I think, in the US policies. And of course then the other approach, which is, as you know, there's some evidence that e-cigarettes can also help people to quit, in which you keep the nicotine but you take other stuff out. Now, I'm not aware of any research done in South or Southeast Asia that have used either of 2 approaches, but I do know that the Swedish research on Swedish snus, which has shown that it does not cause as much cancer or as much health problems as the Southeast Asian products. And one of the reasons is that they do have nicotine. So the nicotine content is there, but the concentration of TSNAs, which is tobacco-specific nitrosamines, is very low. And that is the reason why people can still be addicted to Swedish snus, but they're not having the same problems as we are all having here in Southeast Asia.
If I may just come in and respond, in a completely different angle. I mean, one is that, of course, that smokeless tobacco is cheap. And that's the reason. I mean, at the moment you kind of, look at introducing other forms of tobacco, it just becomes much more expensive. The second thing is that initial trials of varenicline in developing countries, actually, there were very, very high placebo rates. That means people who were on placebos, the quit rates were very much higher. as compared to other countries. And the third thing is that, behavioral intervention does seem to cause a lot of change. But I think the point needs to be underscored that we do not know what amounts of pharmacotherapy to use with different, people using different forms of smokeless tobacco. And that's because of the tremendous variety of smokeless tobacco that's available. So one thing is that people are not very motivated to give up because they don't perceive it. But when they do, unless we can determine, and I think Dr. Kamran has made a very, very valuable point, that there's, if you can determine their phagostroms, their, the severity of dependence, perhaps monitor their cotinine levels, then you might be able to offer pharmacotherapy. The trial on varenicline from India that he talked about is actually very disappointing, but at some, you need very, very strong evidence if varenicline is going to be used as pharmacotherapy, because it's an expensive medication. And you're talking, countries will not easily include varenicline in their treatment strategies if it's not got a very good, treatment effectiveness. Therefore, we are struggling with the fact, and I think, therefore, that public policy looking at at some degree of standardization, so that what to do for such people is also very important, in addition to looking at various forms of interventions.
Very, very true, Professor Murthy. And I think the cost of tobacco cessation, in terms of when you look at pharmacotherapy, and it is not available in that abundance, and then people who are using SLT, they are getting their fix for ₹5, and when you are looking for an alternative for cessation, it is very costly. And the policy also is, in terms of, you do not get the health cost reimbursements, so you would not get pharmacotherapy expenditures reimbursed. So that is another, I think, trouble that from a policy level, from a health insurance level also, I think we need to think if we want to integrate pharmacotherapy into SLT cessation. So I would give first to Dr. I think from Andhra Pradesh. I missed the name, so I'll give him, and then Vikrant.
Yes, so shall I start, sir?
Yeah, please.
Yeah, I'm Dr. Prashant, Program Officer for NTCP Program Andhra Pradesh. I would like to ask the speakers that whether there is any nicotine to prevent the cessation and to take the cessation. The nicotine gum is costing quite a lot of amount to prescribe to the persons. The person may as well think of buying the pouches or sachets of smokeless form of tobacco rather than purchasing this nicotine gum. For example, we have Nicotex manufactured by Cipla. So is there any other gum which is available or cost effective, or is there any organization that is coming up? Because we are planning to have 16 more TCCs in all the dental colleges across the state of AP. So can anyone share some light on this, please?
Let me just go first on this, because I think in terms of our clinical experience, even though granted that we do not estimate the cotinine levels routinely for smokeless tobacco users, we've generally found that smokeless tobacco users are not able to tolerate very high levels of the gum. They develop a lot of side effects from the gum. They develop giddiness, dizziness, gastric irritation, and so on. So we use much lower quantities of gum as far as smokeless tobacco users are concerned. And certainly, we've and both the tobacco cessation clinic experience as well as our own experience at NIMHANS suggest that smokeless tobacco users do relatively better than smoking tobacco users in terms of their quit rates, which is at variance to what what the international research seems to suggest. The third thing is that we have an obligation. So even in spite of NRT being a little expensive, because for people with severe dependence, they would need some form of pharmacotherapy. We need to make it available through the tobacco cessation clinics for people who would desire to quit and cannot quit with behavioral. So to that end, I think at least there are 3 or 4 companies which do make nicotine replacement treatments, and I think governments need to negotiate with the manufacturers in terms of subsidizing this as a public health measure. But I definitely think, some form of nicotine tobacco cessation treatments have to be made available at our health facilities, particularly tobacco cessation facilities, so that people can fit with some help.
Yeah, thank you, Professor Murthy. Dr. Kamran, if you have to add something.
Yeah, just very quickly. I mean, obviously, I cannot comment on what is available in India, but I know internationally we have new formulations of nicotine replacement therapy are available, which are better tolerated and better. They have a more sort of quick response. One of the ways of using nicotine replacement is nicotine strips, which are just small strips that you put it under your tongue, and that gives people very similar kick as they would get from using a real tobacco product. So, but I'm not sure if those products are available in India. One of the problems that a lot of patients have responded that by gum, because a lot of smokeless tobacco users also have rotten teeth, so they have tooth problems as well and toothache. So I think a lot of people do complain about tooth problems by using gums, and therefore that's another reason for not tolerating NRT. But one of the things that I think is not being researched is to use titration. I mean, in medicines, we use titration all the time. We titrate the amount of drugs that we give to people according to their blood levels, according to their. So why can't we do that in the terms of their addictiveness, according to their uh, smokeless tobacco dependency scales or cotinine levels? Because the right amount of nicotine should be given to people so that they tolerate it better and also has an effect in helping them to quit.
Yeah, I think that's a very good point. Thank you, Professor Kamran. Vikrant, you have a question?
I don't think I have one question because the speakers have actually left us with the too many thoughts in our mind, and I'm a big fan of Professor Murthy, and thank you very much, Professor Kamran, for all the insight. My question actually to Dr. Murthy would be is, ma'am, you were very well aware of what we do normally in our experience is we give alternatives like chewing of elaichi and saunf and all that. So what is your experience with such local remedies? Do you have any do you practice such thing? How do you recommend one this? And maybe if you could answer this first, then I can go on with the next question.
Yeah, I mean, I think what I'd like to emphasize is that behavioral interventions themselves are useful.
Yes.
So any kind of little add-on that people can use seems to be effective.
Okay.
So, I mean, I think whatever it is that the person can use, which is available locally to kind of get rid of the urge. I mean, the most important thing is really to distract themselves when they have the urges. And whatever helps to do that, I think is useful. I'd also like to add that apart from NRT, possibly non-NRT medications, particularly bupropion, as well as nortriptyline, is something that we have found useful. Again, no RCTs to that effect, but certainly, particularly, I mean, it might be related to the addiction itself, or perhaps some of the mood-altering properties of these medicines, which might help as well.
Okay. Ma'am, the next thing I wanted to know was you are totally aware that India is focusing on Ayush alternatives, and as recently we just completed a small systematic review on complementary alternative medicine. So what is your take on such interventions in tobacco cessation?
As I mentioned to you, placebo rates are very, very high. So unless, and the difficulties in many of these kind of approaches is a standardization. So yes. I think finally you will have to go back to, as Dr. Kamran mentioned, you'll have to go back to RCTs, very well designed RCTs, if you need to demonstrate that a particular treatment is more superior than others. So I think there are two levels. At the clinical level, what would you do? And of course, how would you use evidence-based research? So at the clinical level, I think you would do things that help people structure their lives, monitor their lifestyles, deal with their craving in as effective a way as possible. And of course, we would wait certainly for evidence-based interventions, especially when the interventions are costed. And I think that's the issue. Drugs like varenicline, the things that are available, they don't have a huge odds in terms of, having huge cessation benefits. And therefore, I think we're still looking for something that is going to be a pharmacological magic wand. So at this point in time, I think we're looking at all kinds of behavioral alternatives. The permutations and combinations of these alternatives is anybody's guess.
Okay. One last question to Professor Kamran. Professor Kamran, this BSI model which you just spoke of, are you actually implementing it in this multi-country trial that you're working on?
Yes, that's exactly what we want to do. Yeah.
Okay. Okay. Fine. Thank you so much.
Thank you.
Okay, we have a question from Dr. Rakesh Mahajan. So it's for Professor Murthy. So he's asking, will you recommend ENDS as tobacco cessation device as being used, especially in UK, considering the addictiveness of nicotine and the side effects already? Already, Government of India has issued an advisory to the states to ban ENDS product.
So, I mean, I think at this point in time, there's really no question of using ENDS for smokeless tobacco cessation when ENDS is not even approved as a smoking form. But I think we need to be extremely careful before we actually recommend something which is not based in sound evidence. And certainly, I would hesitate very much to look at ENDS as an option for smokeless tobacco users when the harm, when the entire safety and effectiveness hasn't been demonstrated.
I think we have covered all questions. Yes. So we have Dr. Mahajan says thank you to Professor Murthy. And yeah, I think we had a very nice discussion this evening, and grateful to all the participants, and very, very, in terms of heartily grateful to Professor Kamran and Professor Murthy for giving their time, and in terms of giving us this opportunity to hear from you and get to know about more issues that are there for smokeless tobacco, particularly for smokeless tobacco cessation, and how the interventions and the research, the policy options that could be there for governments to look at and for researchers to take it from here. And I think we would have subsequent follow-up questions, and if there are any research possibilities and things like those which may come up, we will get back to both the experts, and we hope to get your support in taking this forward from NICPR and from the Knowledge Hub, Smokeless Tobacco Knowledge Hub. Thank you, both of you, and thank you, participants, for joining us. Have a nice evening.
Thank you very much.
Thank you.
Thank you.
Stop.